Okay, Kevin, how's my sound?
I can hear you great.
Perfect. I can hear you just fine as well. Well, let's kick this webinar off this morning. Good morning and welcome, everybody. Thank you for joining us for today's Fundamentals in Healthcare Law webinar focused on Medicaid in Idaho. This, as many of you know, is the 8th of 12 webinars in our Fundamentals of Healthcare Law series. Many of you have joined us for all 8, and we thank you for that. We've got 4 more coming, and we hope that you'll join us for those as well. Our next webinar is scheduled on Wednesday, May 18th from 8:30 to 9:30, and we'll focus on commercial insurance. And as you all know, we've been doing these the third Wednesday of each month in that 8:30 to 9:30 time slot. My name is Jason Castor, and I'm the Chief Business Development Officer for Parsons, Behle, and Latimer, and I'd like to welcome you to today's presentation. Thanks again for taking the time out of your busy schedules to be with us this morning. Before I turn the time over to Kevin, I'd like to cover just a few quick logistical items. First, today's webinar is being recorded, and we will provide you with a link to the email recording to share with your colleagues and teams. This email will also include a copy of today's PowerPoint presentation, so you'll have the notes and information at your fingertips. Second, we have a lot of time at the end for Q&A, so please use the chat feature throughout today's presentation to submit your questions, and we'll do our best to address your questions and provide answers at the end of today's presentation. And last but certainly not least, it's important to note that today's presentation is considered a general source of information and is not intended and will not serve as a substitute for legal counsel on these issues. Please do not act upon the information provided without consulting your legal counsel. All right, with housekeeping items aside, I'd like to now introduce Kevin West. Kevin is a shareholder in the firm's Boise office and is the chairperson of our firm's health law department. He has extensive experience representing healthcare providers in a variety of matters, including audits, investigations, medical malpractice, and licensure board disciplinary matters. Kevin, welcome. Thank you. I'll turn the microphone and floor over to you.
All right, thank you very much, Jason. I appreciate it, and welcome everyone this morning. I really appreciate those who have been joining us throughout this year-long venture that we've been involved in, and thank you for your participation. I have a small caveat. I usually do these presentations from my office when I speak. Today I happen to be on the road traveling in California, so I'm coming to you from a hotel room, which always creates a little anxiety about strange noises or whatever, so hopefully things will go well this morning. All right, well, we are going to talk about Medicaid today. For those who participated last month, we talked about the Medicare program in as much detail as 50 or 60 minutes would allow. And today we'll talk about a related program, the Medicaid program, which in some ways has become Medicare 2.0, but the programs are different, and you hear lots of lay people use them interchangeably, Medicare, Medicaid. Obviously they are different programs, but they are related. So in terms of talking about Medicaid, you know, it's very overwhelming to try and do justice to a subject as broad and complex as Medicaid in this short amount of time. So obviously we're going to stay on a somewhat broad and superficial level, not a ton of depth here today, but hopefully give all of you a good working knowledge of what the Medicaid program is about. And this is sort of an agenda of things that we'll hope to cover in today's presentations. So starting with Medicaid Basics, to understand Medicaid in Idaho, we have to understand Medicaid globally, because no state Medicaid program can be divorced from its national parameters. So some big picture things about Medicaid. It was enacted back in 1965 as part of a broad package of legislation, part of what was called the Great Society legislation of many social welfare societal safety net programs that were put into place. It was originally intended to help the very poor in certain narrow categories. And like most social programs, Medicaid started out with a very narrow focus and very narrow parameters. And that has certainly changed over the years. It has now become something much bigger. Critics might say something bloated and huge and far beyond the scope of what was originally intended. So when I say that, what am I meaning? Medicaid, in fact, and this is a surprise to people, Medicaid is the largest health program in the United States in terms of numbers or enrollment. Medicare expenditures are bigger, but the number of people in the Medicaid program is actually the largest. And as far as state budgets, Medicaid is one of the largest components of those state budgets. Just, I guess, going back on that point, this morning I looked at the latest enrollment numbers. Medicare enrollment is 64 million right now in the United States. Medicaid enrollment is 75.5 million. So you see a comparison, over 10 million more people nationally enrolled in Medicaid than in Medicare. All right, so it's always helpful to maybe contrast and compare Medicaid versus Medicare. So with Medicare, it is completely administered by federal rules, federal contractors, etc. The benefits are entirely defined by federal law, and the payment for Medicare services are totally from the federal government. And it's designed primarily to care for the elderly, but also there is a component for disabled people. Those that have been on Social Security disability for 24 months are automatically qualified and enrolled in the Medicare program. By contrast, Medicaid has state administration, however, with significant federal oversight. And we all know that whenever the federal government sends dollars to a state, there are always strings attached. And those strings involve a great deal of federal oversight of the state Medicaid agency. The benefits can be defined by each state, but there has to be at least compliance with some federal minimums in setting out those benefits. So if you go from state to state in our country, you will see a different array of packages available under the Medicaid program, but once again, they all have to meet certain minimums. The payment is in part by the state, in part by the federal government with matching funds. And this program is designed to help low-income people, dependent children, elderly with disabilities. So you can see there is some overlap with Medicare, the Medicare program. It's really interesting. At one point, I thought that this federal matching was simply the same from state to state, and in fact, it is not. And with 13 states, the federal match is 50%. With 14, it is in the 50 to 60% range. And you see it goes all the way up to the lucky 11 states, including Idaho, by the way, which get 66 to 75% federal match. And the amount the government pays is known as the FMAP, or the Federal Medical Assistance Percentage. And you might ask, why is it so different among the states? And there are various factors. I don't totally understand the formula, but a lot of it has to do with how recently the state accepted Medicaid expansion. And those states that accepted that most recently were essentially, if you want to be cynical, lured into Medicaid expansion by the government promising a higher federal match initially. That goes down over time. And as you see on the slide, the FMAP is adjusted each year by CMS. So many states got brought in with the government saying, hey, we'll match you at 25 or at 75% to your 25%. And many states, including Idaho, were attracted in by those numbers. And that is going to change over time, unfortunately. So to get these matching dollars, what do states have to do? Obviously, it's not too exceedingly difficult, since all 50 states and the District of Columbia all participate. They've all qualified. There are three things. You have to designate what they say a single state agency, and sorry for the typo, to manage the program. All states have done that. States have to submit a state plan or amendment to CMS, the Centers for Medicare and Medicaid Services, and obtain approval of that plan. So those are the basic things that a state has to do to qualify. And as I said, all of them have been successful in doing that. Again, talking about the financial impact, Medicare constitutes, and by the most recent numbers I've seen anyway, about 15% of the entire federal budget. That's a lot of money. Medicaid is, again, just on the federal level, about 10%. So those two items by themselves, Medicare and Medicaid, make up a fourth of the entire federal budget. And that number is growing from year to year. Medicaid now in the United States is one of the biggest payers of long-term care. 40% of all long-term care, which mainly is nursing home care, is now being paid by the Medicaid program. So who is eligible for Medicaid? It's more complicated than one might expect, and the slide you see in front of you is a oversimplification, really. It is restricted to U.S. citizens, but also includes quote unquote qualified aliens, which again is a somewhat complicated definition, but it includes those here legally. It does not include illegal aliens, but those here legally, and those who, for example, have green card status and who are living here on basically a semi-permanent basis with a legal status here. Now, that's except for emergency services, and even those who are not qualified aliens or U.S. citizens can receive Medicaid services for emergency care. Now, for those who meet the first bullet category, there are then really two major categories, what are called the categorically needy and the medically needy. And these categories are important to understand. So categorically needy means those people who fall below the federal poverty level, or the FPL. And this includes low-income children, age blind and disabled, pregnant or postpartum women, these special categories, but the basic criteria is falling below the FPL. And then there is the medically needy. These are families or individuals who make more than the FPL, but because they have high medical expenses, they call it spending down. They spend down to below the FPL. So for example, a family that may have $40,000 in income and the FPL is $20,000, and that family has medical expenses in excess of $20,000, they would likely fall into the category of being medically needy. So what is the FPL? Right now in the 48 states, excluding Alaska and Hawaii, which have different scales, the The FPL for a single person right now is $13,590, and it adjusts per person. I've just picked out a family of 2, family of 4, and you see for a family of 4, it's $27,750. So these are the eligibility factors that tie into who qualifies for Medicaid. As far as benefits paid, once again, federal law mandates a minimum set of benefits that must be provided to Medicaid beneficiaries. Those benefits, again, may vary depending on whether one is categorically needy or medically needy, according to the definitions I gave before. And once again, the benefit packages become somewhat complicated, and no way I'm going to go into that here, but just understanding it is not the same benefits. It depends on the category that you fall into. And then states can obtain waivers from the federal government to modify their benefits packages, and they still have to, again, meet some minimum requirements. But once again, states from one state to another vary dramatically. Some states do not cover certain services like dental or podiatry services, for example, based on their particular benefits packages. There is a program that is related to Medicaid that has to be mentioned. It's the S-CHIP program, which really kind of covers what's considered to be a gap, which with parents who are above the FPL but cannot afford health care for their children. There is this program that operates very much like the Medicaid program, is kind of an adjunct to it. So in terms of reimbursement for providers, states are allowed to set their reimbursement rates, once again, as we keep repeating, consistent with federal minimums, but beyond that, the states can vary their reimbursement rates to healthcare providers. The states can obtain waivers in terms of whether they charge premiums to certain people or deductibles or copays. And over time, we have seen an exodus from the Medicaid program because of the strict requirements it has, and sometimes because of low reimbursement to providers. I mentioned the word waivers, and that's become an important factor in recent years as the federal government has given authority to states to customize their Medicaid programs. I mentioned increased copays. There are now behavioral incentives. There are work requirements that some states are imposing, and there can be mandatory versus optional categories of benefits. So the states have the ability to apply for waivers, to customize their programs, and that is happening in many states around the country. Medicaid expansion is a critical thing, and really in 2010, with the passage of the Affordable Care Act, the Medicaid program really did change forever. Many states accepted, or most states accepted, Medicaid expansion. That has evolved over time. Idaho is one of the most recent adopters of Medicaid expansion, which happened effective in 2020. So really, Idaho has been very recently accepted or accepting Medicaid expansion. And what is the impact of Medicaid expansion? So what it does, it increases the pool of eligible people to not just the FPL, but to 138% of the federal poverty level. And the impact of this has been to add 12.5 million people to the Medicaid program nationally. Medicaid expansion and the Affordable Care Act have added mental health services, prescription drug rebates, and certain other benefits. And as I mentioned earlier, what happened with Medicaid expansion was that states were lured in by favorable matching rates by the federal government, and that attraction is going to diminish over time. So going back to the chart I showed you earlier on the FPL, you see the impact that this has. For a single person, it's now $18,000. For a family of 4, now $38,000. And, you know, from a political standpoint, when the Affordable Care Act was passed, it was touted as providing health insurance to many more Americans, which in fact it did, but that addition was in the area of Medicaid. So there were many, many people added to having health insurance coverage, but they were added to the rolls of the Medicaid program as opposed to private insurance like Blue Cross Blue Shield. That's really where the change happened in that particular area. And again, depending on your philosophical background, you may think that's a good thing. Other critics would say, no, that's not a good thing to be adding to the existing budget deficits and to be increasing the size of certain social welfare programs. All right, we're going to pivot at this point and now talk a little bit more specifically about Idaho Medicaid. And here we're going to focus on certain aspects that are somewhat unique to Idaho. You know, most of what I do as a lawyer is defend healthcare providers who are having problems, audits, investigations, or whatever by Medicare, Medicaid, or commercial insurance. So I tend to focus on the types of laws that impact healthcare providers, may cause them to have trouble or be investigated by the government. And so I could have picked many, many different aspects of the law to cover, but I'm going to cover certain ones that I seem to be involved with from time to time. So one of those is the Idaho False Claims Act. Now, there is a federal False Claims Act, which is very broad and comprehensive. The Idaho version is a mini version, and it provides that those who submit false claims to the state Medicaid program have violated this particular law. And there are different consequences of those violations. One is that you can be excluded or terminated from the Medicaid program. And as we'll talk about later, there are other penalties as well. And it's important to understand this idea of what constitutes a false claim, because that's what triggers liability under this law, both at the federal level and the state level. And it requires that the government prove intent. And there are 3 levels or 3 standards of intent that can be shown. And these are in either or. So either you have actual knowledge that the claim you submitted was false, or you submitted a claim being deliberately indifferent to whether it was true or false, or you had a willful disregard for whether it's true or false. And these are very legalistic terms, which the second 2, deliberate indifference, willful disregard, sound very much the same. I think the basic idea is you simply didn't care whether what you were submitting for payment was true or not. And so these are the standards that the government must show if they're trying to show a healthcare provider has violated the False Claims Act. Another statute, again, we have a federal anti-kickback law, and Idaho has its own mini version of that, which is much narrower. And the basic prohibition of the Idaho anti-kickback statute is that Idaho healthcare providers cannot pay someone else to get a referral of a patient, nor can they engage in a regular practice of waiving or rebating copays or deductibles. That is considered to be a violation of the statute. And the key word there is regular. There are times when providers may waive a copay or deductible because of financial necessity, and there are exceptions that allow that kind of thing to happen. But a regular practice for all patients of waiving copays or deductibles is considered a violation. Most even non-government health insurers like Blue Cross or Blue Shield also consider that to be an abusive or fraudulent practice. There can be a $5,000 fine per incident for this, and if there are many referrals you've obtained in that way, that can be a very large number. And once again, a violation of this law can cause you to be terminated from the Medicaid program. The federal law has something called the Stark Law, which is a prohibition against what are considered self-referrals. Idaho has its version of that. It largely follows the parameters of the federal law. And once again, violation of this law can result in denial of payment of claims and may also result in termination from the Medicaid program. And the basic idea of this self-referral prohibition is that you cannot refer patients to another healthcare provider, particularly a healthcare entity in which you have a financial interest as a healthcare provider. That's the general rule. There are many exceptions to that general rule, and it's an extremely complex area of law to determine what is or is not a prohibited self-referral. And there are huge carve-outs for certain things like, for example, ambulatory surgery centers. Physicians are allowed to refer patients to ambulatory surgery centers that they own or have a financial interest in under certain circumstances. The same is true with imaging facilities, and there are numerous other exceptions that exist out there. Idaho has, somewhat unique to Idaho, but there are a few states around the country that have this, what is called a fee-splitting statute. And Idaho's law says that if you are a physician or a physician's assistant, and I do not know why they have narrowed it to those two only, but you cannot divide your fees or agree to do that with any other person or entity in return for them referring a patient to you. You cannot give or receive a rebate. That is also considered a fee splitting, and there's a definition of what a rebate amounts to. And this fee splitting is a violation of the Medicaid provider agreement, and once again can result in a provider being terminated from the program. So important to be aware of that if you are a healthcare provider in the state of Idaho. Continuing to talk again about some things unique to Idaho. When a healthcare provider joins the Idaho Medicaid program, they sign an extensive provider agreement. I'm sure that many providers do not take the time to read this from cover to cover, but they should, because it does contain important requirements. For example, it requires that providers comply with many federal and state laws, rules, and regulations. And those laws and regulations comprise hundreds and hundreds of pages of different regulations. We've talked about a few of them in the prior slides with kickbacks and self-referrals and fee splitting, but there are many, many other provisions of which providers need to have at least some general awareness. The provider agreement with Medicaid says that providers must maintain records for at least 5 years. And I usually give as a rule of thumb that providers should always keep their medical records for at least 7. And this certainly falls within that. With the Medicare program, it's at least 6 years. So with Medicaid, it's at least 5. When Medicaid providers in the state of Idaho submit claims, there's a certification on those claims that is required that the particular service is medically necessary, which is a defined term under the law, that the service was actually provided, and that the service was provided in accordance with professional standards in your particular specialty. And the importance of that certification cannot be overstated. We talked a moment ago about submitting false claims. And so a false claim could be one in which those 3 items are not represented accurately on an intentional or deliberately indifferent basis. So very important, when a provider submits a claim, they are in some respects putting their reputation on the line in certifying that the claim is a valid claim. Medicaid providers are required to verify the eligibility of Medicaid patients and also verify that they are enrolled in the Healthy Connections program, which we're going to talk about momentarily. And usually this is achieved by looking at someone's benefit card, but there may be circumstances where more effort is required by a provider. So an important provision, sometimes not well understood in the Medicaid provider agreement, is that providers must accept Medicaid payment as payment in full. So whatever that amount is on the Medicaid fee schedule, if a provider submits a claim, they must accept that. And they cannot go to the patient and ask them to pay some remaining balance of what the provider thinks they should be entitled to. So for example, if the Medicaid fee schedule for an X-ray is $50 and the provider usually charges non-Medicaid patients $100, the provider cannot submit a claim to Medicaid and get their $50 and then charge the patient for the difference. That's called balance billing. That's not allowed under the Medicaid program. All right, Medicaid reimbursement in Idaho, once again, has a somewhat complicated formula. Boiling that down to its essence is that providers are paid the lowest of the provider's actual charge for that particular service, or the Medicaid fee schedule amount, or for someone who is considered a dual eligible for both Medicare and Medicaid, they get the Medicaid fee schedule amount minus the Medicare payment amount. So that can be a complicated formula there, but I will comment on that first bullet. Sometimes providers may have special discounts that they give, for example, to cash paying patients. And that can sometimes get a provider in trouble when they are billing Medicaid, because if a provider bills $30 for an X-ray to an uninsured person on a cash basis, but then they bill $50 to Medicaid, Medicaid has been known to argue that the actual charge is the $30 amount, and we want to be paid what your actual charge is for a particular service. So providers have to be very careful when they go about doing special discounts that Medicaid may claim to have also a most favored nation status in getting that lower amount as well for their payments. All right, let's talk about an important component of the Medicaid program, which is known as the Healthy Connections program. This is the case management model for Idaho Medicaid. It is a tool for controlling costs. It's a tool for making sure that services received by Medicaid beneficiaries are actually medically necessary and appropriate. And the way it works is that a primary care provider is required in many instances, and again, there are exceptions, but in most instances, the patient's primary care provider must make a referral to any kind of specialized care beyond the primary care provider's care. And those services that require such a referral are listed in the Idaho Medicaid Provider Handbook. So providers need to make sure they are checking with that, because not only will the patient not get their benefit, but the provider may not get paid. And I have defended providers in multiple audits in Idaho where there either was not a Healthy Connections referral or there was not documentation of it. And in those situations, Medicaid asked that the money be returned to them for the services that they had paid for. Now, can any primary care provider make a Healthy Connections referral? And the answer is no. There are only a certain pool of primary care providers who are allowed to do that, and they are those who have applied and have been accepted as authorized Healthy Connection care providers who can make referrals. Those providers can only manage a certain number of Healthy Connections patients as their primary care provider. I do not know what that number is, how many they can do, but it is limited. They cannot simply take all comers. And those primary care providers, unlike everyone else who is just paid on a fee-for-service basis, these providers are paid on what's called a capitated basis, meaning a fixed amount per patient. And that capitated or fixed amount is determined on a number of factors: age of the patient, their different conditions or diagnoses. So this is a unique and important part of the Idaho Medicaid program as a management tool to keep costs down as low as possible. Of course, like any insurance coverage program, there are excluded services. This is a short list. There's a much longer list, but some of the notable things: cosmetic surgery, not covered; acupuncture, naturopathic services, and services which are considered to be experimental and investigational. And I would say that last category can be very problematic for providers, because oftentimes the newest and greatest technology or medical device comes out. Providers are convinced by a vendor to start using it, and it may work great, but it is not yet accepted as standard of care. It is not yet accepted in the general medical literature. And until a type of service or device falls into the realm of being accepted, it may be denied as being experimental and investigational. And government payer programs, it should be noted, are not required to pay for the best possible care. They are only required to pay for care that meets accepted professional standards. So very important, sometimes not to be necessarily cutting edge in the services that are being provided to patients, to stay within standard of care, to stay within what other colleagues are doing in your particular specialty. All right, let's talk for a moment again about an area that I work in, and that is defending audits of Medicare providers and the area of enforcement. First of all, it's important to understand that you cannot even be a Medicaid provider unless you go through an application and screening process. And this is not necessarily like a very thorough background check, but there is some background check and screening that is done. And it's also important to note that all states are required to do one of two things: either to have their own Medicare fraud unit, or that they have contracted with an approved contractor to do that function. Idaho has its own dedicated Medicaid fraud unit, and that unit is tasked with doing audits, making sure that state dollars and federal dollars are not being wasted by fraud and abuse. And I just use a term that needs to be defined. Medicaid fraud units are on the lookout for fraud and abuse. So what do those terms mean? Abuse basically is defined as being practices, in particular billing practices, that are not consistent with sound business practices, child care, medical practice, those types of things, particularly those that result in unnecessary costs or in medically unnecessary services. So for an example of that might be a provider who takes x-rays for every single visit that a patient has, or for every initial visit, when the standard of care does not necessarily require that x-rays be done on every initial visit or every visit thereafter. That would be considered Medicaid abuse, because the service, though it's being provided, is not considered to be medically necessary. Failing to properly document services is considered to be Medicaid abuse. So abuse is considered to be a violation, but the more serious is, of course, fraud. And we've already talked about earlier the level of intent that has to be shown to prove Medicaid fraud or a Medicaid false claim. What are some examples of Medicaid fraud? Well, you could give hundreds, but the most blatantly obvious is simply billing for a service that you did not provide. But there are many different variations. What's something that's called upcoding, so intentionally billing for a higher level of service than what you actually provided. There is what's called unbundling, where instead of using a single billing code, you break it out into multiple billing codes, which in combination pay a higher amount than the single code. There is also a somewhat rampant problem with providers billing for services when they are not credentialed, or allowing their billing number, their Medicaid billing number, to be used to submit services for those that are not credentialed and participants of the Medicaid program. So we often will see this with providers who, an older provider brings a younger provider into their office. The younger provider is not yet credentialed with Medicaid, but they are seeing Medicaid patients, and they are billing for their services using the older provider's billing number. That is considered to be Medicaid fraud, and it can be a very serious problem. So what can Idaho Medicaid do if a provider is found to have engaged in either abuse or fraud? Well, there's quite a list of things that can be done, all of them unpleasant. And you see the list. They can deny reimbursement or seek to recoup reimbursement that has been paid previously. And that's considered recouping an overpayment. So if a provider was paid something they weren't entitled to, that is called an overpayment, and they can come back with an audit and recoup that money. A provider can be suspended from the Medicaid program, and that is a serious thing in and of itself, because that is often a reportable matter to either the National Practitioner Data Bank or to a state licensure agency, which then results in greater and even worse ramifications for a healthcare provider. Not only can they suspend a provider's status, but they can also potentially leave the provider as a Medicaid provider, but they can suspend payment and hold payment in escrow until an investigation is completed. So a provider may be seeing patients for Medicaid, but that money will be withheld until there is a determination about whether there is a problem or not. The provider agreement can be terminated completely, and the provider essentially excluded from the Medicaid program. There are what are called civil monetary penalties. More on that in a moment. There can be criminal prosecution in the most serious situations, and I have unfortunately been involved in a number of those cases as well. And as stated earlier, the provider can be reported to the state licensure board, which then may or may not take disciplinary action against a provider's license. These Medicaid audits are often conducted on site. There's really two ways an audit can begin. The provider can get a letter saying, "You're under audit, please send charts," and they give you a list of charts that they want you to send in. Or the investigator can show up at the provider's premises with a list, and in many situations they will request or demand to actually physically photocopy or print out the medical records right then and there. And that is often very inconvenient and can create problems with seeing patients when that's going on. And I often advise providers to be very careful in these situations. If they can negotiate a more convenient time and setting, by all means, they should try to do that. But the law does require that providers provide quote unquote immediate access, and there are severe consequences for failing to do that. Audits of Medicare providers can involve statistical sampling, where the investigator will take a statistically valid random sample of records, compute an overpayment, and then extrapolate that overpayment to the universe of the provider's Medicaid patients. And as you can probably guess, that can result in very significant amounts of money. For a provider who is found to have committed abuse or fraud, there is a hearing and appeals process that can go all the way from the Medicaid hearing officer into district court in Idaho. I've been involved in a number of those proceedings. And I tell providers, from the moment you are first contacted by an investigator seeking to do an audit, you need to get legal counsel involved. These investigators may be very friendly. They may act like this is just routine and no big deal, but trust me, they are not your friends, and they are not there to help you. They are there to determine whether there's a possibility of taking money back from you that you've been paid through your hard work and efforts. Documentation requirements, very important to understand if you're a Medicaid provider. your medical records must be created contemporaneously. And if you are behind on your charting and are coming back weeks or months later, Medicaid may deem that not to be contemporaneous, and it may not meet the requirements for payment. The records must be legible, which is not as big a problem in today's world with electronic medical records, but there are still some providers who do a lot of handwritten notations, and those must be legible. The way you keep your records must be consistent with professional standards. You cannot have your own secret shorthand or codes. You have to document in a way that's going to be recognized and acceptable. And as stated earlier, you must keep the records for at least 5 years. This point about granting immediate access, if investigators come on site, you must allow them or negotiate with them a time for them to copy or look at your records. If they simply ask you in a letter for copies, that typically has to be done within 20 business days. And again, the failure to do this can result in suspensions of a provider and them being terminated from the Medicaid system. And I have seen some providers become very defiant and tell the investigator to go away. And again, that is a very, very bad idea for the reasons we've stated. We talked earlier about civil monetary penalties. Not only can Medicaid ask for the payments they've given you to be returned, but in addition, they can also assess penalties against a provider. And it's very important to note that not only the provider, but also the organization itself and officers, directors, and owners. This is different than Medicare. So the liability here is broader just than a provider, but can also extend to the entire organization and their owners. And these penalties can be up to $1,000 per claim, or if there are multiple penalties, then 10% of the total amount of the claims, whichever is less. And Medicaid will look at aggravating factors. You know, is there multiple problems? Does it seem to be intentional versus just negligent? And these penalties can be increased based on that. There is a term that has come into use in recent years. The term is dual eligible, which is patients who qualify for both Medicare and Medicaid. And there are complex formulas, there are processes that have to be followed by the state in coordinating and integrating benefits. These patients must typically have what's called a Medicare, Medicaid coordinated plan of care. In many states, I believe, including Idaho, they have to be enrolled in a Medicare Advantage plan, which is a managed care plan. And the patient must be at least 21 years of age to participate in this way. So again, I did have a slide here about some estate planning issues. I'm not going to go into that here because we're out of time. So I am going to, at this point, see if there are any questions that have been submitted. And Jason, I'll turn that back over to you.
Great, Kevin. Thank you very much. A great presentation today. I think the one takeaway from me from your presentation was auditors are not your friend, and engage legal counsel when that issue arises. Hey, in our remaining moments of time here, if you have any questions that you'd like Kevin to address, please feel free to submit them via chat. We've got a couple of minutes left, and we'd be happy to address any questions that you may have. While we're waiting for questions to come through, I just wanted to remind all of you that you'll receive a copy of today's PowerPoint presentation and a link to the recording of the webinar. Also, as I mentioned at the outset of today's presentation, our next webinar is scheduled for Wednesday, May 18th from 8:30 to 9:30, and this presentation will focus on commercial insurance. You will receive an invitation by way of email to this event. along with the materials that, the link to the recording and the PowerPoint. Kevin, as we're waiting for questions to come through, any final takeaways or summary points that you'd like to share with the group?
Well, I guess one thing I will comment on is for those who have been attending with us over these months, you're going to have really a very big picture of the entire structure of payers. We've done Medicare now, we've done Medicaid, and next month we will do commercial insurance. So in those 3 months or units, you're going to get the entire big picture of the payment structure in the United States for healthcare services. So that's a nice overview of that. And if you're a healthcare provider or work with one, that I think will be a valuable perspective to you. In terms of Idaho Medicaid, I guess my biggest point would be, if you're going to participate in a government program, you need to understand the program. You cannot wade into it with a half-hearted effort and expect to be able to navigate really the many requirements and hurdles that exist. So it's one thing to enroll and participate, it's another thing to do so in a knowledgeable way. So I would encourage people to become informed if they are a participating provider.
Well, great takeaway, Kevin. Thanks again for taking the time to put the materials and the information together for today's presentation, and all the work that you've done in coordinating our Fundamentals in Healthcare Law webinar series. And to all of you who joined us today, thank you for carving out an hour of your morning to be with us. We'll look forward to seeing you hopefully on May 18th from 8:30 to 9:30. And keep your eyes peeled for the invitation and the materials that will be forthcoming via email. Thanks again for your support, and we look forward to talking to you soon. Thanks, Kevin.
Thanks, everyone.